this is Stephanie McNeal for NSC 892. According to the 2012 U.S. Renal Data Systems, over 640,000 people were diagnosed with end-stage renal disease in the United States. Worldwide, over 80% of end-stage renal disease patients have hemodialysis as their renal replacement therapy. Patients on hemodialysis face challenges because of their illness and the restriction hemodialysis places on their physical, social, and mental health. Teaching patients responsibility for assisting in their life-sustaining treatment will strengthen them psychosocially. It will increase independence and improve quality of life for the outpatient hemodialysis patient. Noah Pender's health promotion model relies on the concept that primarily health and well-being is the responsibility of the individual patient. Pender encourages promoting patients to be more active in hemodialysis sessions, and by giving them a sense of self-determination, the goal is to increase the positive emotions associated with regaining control of their care, which will reflect in higher scores on the Kidney Dialysis Quality of Life Survey. There are published studies that support this concept. In 2009, Kring and Crane report the end-stage renal disease patients adjust their lives based on the challenges they deal with to maintain a life on dialysis. In 2011, Painter, Ward, and Nelson reviewed the importance of physical activity in individuals with end-stage renal disease. This study results found that approximately 20% of end-stage renal disease patients have any regular exercise activity. In 2010, Clarkson and Robertson found emergent schemes showing that end-stage renal disease patients have to adjust their lifestyles to live a life on dialysis. In 2011, a study by Lingerfelt and Thornton found that patients respond to educational information and speculated that with increased knowledge comes the improved outcomes and adherence to therapy. In 2011, Wang and Chow found supporting evidence that interactive educational tools can promote a patient's knowledge and decrease their feelings of powerlessness. Janie Wells in 2011 reports that patient educational needs are ongoing and that provider encouragement and re-education are necessary. She also reported that although education yields improved knowledge, it did not affect treatment compliance. In 2012, a study in Taiwan by Chen generated findings that support increasing face-to-face interventions can improve outcomes for patients and improve their self-care activities. My project was a staff educational session, and during that session I reviewed the statistics of end-stage renal disease and hemodialysis treatments. The previously mentioned studies were reviewed. We introduced briefly Noah Pender's health promotion model. I reviewed the company's policies that are already in place to promote improvement of quality of life of a hemodialysis patient. I reviewed the Centers for Medicare and Medicaid Services regulations that apply to outpatient hemodialysis staff education and infection control. And finally, we talked about the role of the provider to encourage patient independence and self-management with their care. To evaluate the project, the positives were that it was a well-received project because the staff had not had an organized educational session dealing with patient quality of life in over a year. They found it to be very educational and informative. Some of the other aspects is that the company already has an educational department in place. So this could be utilized in the future if any further educational information for Noah Pender's health promotion model were to be used. They could disseminate education and teaching from the physicians all the way down to the patients in an organized fashion company-wide, which is an international company. The company already completes quality of life surveys on every end-stage renal disease patient annually by the social worker, so it would be easy to track the success of a program if it were to be initiated. The negative is that the company does have a staff productivity clause, and it does not allow or take into concept the one-on-one educational time needs that a staff would have to educate patients and to promote teaching and self-managed skills. So if this were a project that the company would in the future undertake, those things with that clause would have to be adjusted. And then wrap up, with the use of Pender's health promotion model and ensuring that patient independence within the outpatient dialysis setting can improve the patient's quality of life. It's the main thing to remember is that our goal is to take patients from living on dialysis to patients that are living life and just happen to be a dialysis patient. Thank you for your time.